For over a century, physicians have been trying to map an invisible force inside the human chest. Every mechanical pump of the heart is completely controlled by a complex electrical matrix. To understand how the heart is working, you first have to capture and translate that electricity. This graph charts the electrical action potential of a single ventricular cell. It begins with a rapid influx of sodium, spiking the voltage upward in phase 0. Next, calcium enters to maintain a prolonged plateau during phase 2, keeping the muscle contracted. Finally, potassium exits the cell during phase 3, dropping the voltage back down to its resting state. When we zoom out to the whole organ, this cellular process originates at the sinoatrial node. The signal sweeps through the upper chambers until it hits a highly specific roadblock, the atrioventricular node. Here, the electrical current is intentionally delayed by 0.13 seconds. After that brief pause, the signal escapes the AV node and shoots rapidly down the center septum of the heart, traveling through the bundle of His and wrapping around the thick muscular walls via the high-speed Purkinje fibers. That 0.13-second delay at the AV node is a physiological necessity. It gives the upper atrial chambers exactly enough time to contract and mechanically fill the lower ventricles with blood before those massive lower chambers receive the signal to squeeze. But an electrocardiogram doesn't actually measure the total volume of electricity in the heart. Instead, it measures the voltage difference between tissue that is actively depolarizing and tissue that is resting. To capture these voltage differences from multiple angles, we rely on a geometric system developed by Willem Einthoven in the early 20th century. By placing electrodes on the right arm, and left leg, he created a triangular viewing window around the heart. Looking at this diagram of Einthoven's triangle overlaid on the chest, we can see the axis of lead 2 pointing downward and to the left at a positive 60-degree angle. This brings us to the unbreakable rule of reading an ECG. Whenever an electrical current moves towards a positive electrode, the machine records an upward positive deflection on the paper. Because the heart's overall electrical momentum, its mean electrical axis, points down and to the left toward the apex of the left ventricle, it runs almost perfectly parallel to lead 2. As a result, when you read a standard ECG, lead 2 typically displays the tallest upward spike. This split-screen animation shows the exact sequence of how that geometry is drawn. As the atria depolarize and the signal spreads from the SA node, the pen records a small positive bump. We call this the P wave. As the signal hits that mandatory roadblock at the AV node, no new current is moving through the bulk of the heart muscle. The pen goes quiet, drawing the flat horizontal line known as the PR segment. The moment the signal escapes the AV node and flashes down the rapid Purkinje fibers, a massive amount of ventricular tissue depolarizes all at once. The pen reacts violently to this large current, drawing the sharp, high-voltage spike we identify as the QRS complex. Finally, the ventricular muscle cells have to reset. As potassium exits the cells during repolarization, the electrical gradient shifts over a slightly longer period of time, causing the pen to draw the broader, slower curve known as the T wave. Those abstract squiggles on the paper are actually a predictable, real-time, two-dimensional map of a three-dimensional electrical wave moving through cardiac muscle. By measuring the specific shapes and the gaps between them on this clean 12-lead tracing of normal sinus rhythm, we establish our healthy baseline. Once we know the baseline, we can spot mechanical failures in the heart by looking for where the geometry breaks. If the AV node becomes diseased or damaged, it holds on to the signal for longer than normal. When the gap between the start of the P wave and the QRS complex stretches beyond 0.20 seconds, we diagnose a first-degree heart block. Or the sinus node might lose control entirely. If the atrial tissue begins firing chaotically from multiple locations, the distinct P waves disappear into a jagged, quivering baseline. Because the AV node is bombarded irregularly, the sharp QRS complexes occur at unpredictable intervals. This is atrial fibrillation. For potentially fatal events, we look at this specific zoomed-in heartbeat tracing. The exact point where the QRS complex finishes its sharp descent and meets the flatter ST segment is called the J point. When the ventricular muscle is starving for oxygen, it cannot repolarize correctly, generating an abnormal current of injury. If we draw a horizontal reference line straight across from the flat baseline between beats and see the J point and the ST segment elevating significantly above it into this distinct shape, we have identified an acute myocardial infarction. Mastering these visual rules allows a clinician to take the microscopic electrical distress of millions of dying cells and translate it instantly into actionable geometry.